high TMB. So in pancreatic cancers and biliary cancers, there is significant clustering below high TMB values, whereas in colorectal cancers and to some extent in esophagogastric cancers, there is a percentage of tumors which have a high TMB, which means that these are the tumors where you can look at extending the role of immunotherapy. And further studies have shown exactly the same, in that this was a large study of 375 tumors, where, as you can see, that high TMB tumors were essentially colorectal cancers and small bowel cancers, while in biliary tract and pancreatic cancers, you really had very low TMB values. Another interesting point is that there were differences in TMB between the primary and metastatic sites. So that is something that is worth looking into and exploratory. I just shared this data based on a correspondence to NEJM, where they, even in rare tumors, they try to find a formula to predict for response based on the TMB rates. And this is interesting in terms of rarer tumors, where they use TMB to evaluate responses to immunotherapy. That said, one thing that we should know is that there is very good correlation between TMB and MSI high. So if in GI cancers, as seen in this data set of more than 4,000 tumors, approximately 4% of patients are MSI high, 5% are TMB high. So you're going to pick only 1% more likely of tumors where you can think of immunotherapy. So that is to be kept in mind when we order the TMB via NGS in gastrointestinal cancers.
You can summarize.
Sure. Just to summarize, I think the topic is valid because NGS is becoming more and more available with decreasing costs. It is a one-stop solution for biomarkers, and you'll probably pick up mutations which will not be picked up only by Sanger, but the use of NGS in finding targets is still limited. Colorectal cancers, gastric cancers, and cholangiocarcinomas are well served with NGS. Limited applicability currently in pancreatic cancers, and there is excellent correlation of TMB with MSI, and a small percentage of patients with MSI stable, but TMB high will be candidates for immunotherapy. With that, I'd like to thank you for your kind attention.
Anand, thank you so much for sticking to your time. One question we got, I think that we have already crossed the time, so you can answer, you can type the answer. Please go to the in the question answer section and answer that question. So thank you so much, Dr. Anand. Now I will call upon Dr. T. Raja. He is senior consultant and senior consultant medical oncologist from Chennai, Apollo, and he is going to talk on advances with the novel HER2 targeted therapies and other agents into current clinical practice. So over to Dr. Raja.
Thank you, Dr. Warrior, and I thank Dr. Vineet Talwar and the entire organizing team for accepting me to be here, and it's a great privilege to join you all. My topic is about the HER2 positive diseases, gastric adenocarcinoma. So let's see what we can do in the 15 minutes. So what is the incidence of HER2 overexpression or amplification? That's the first question. 7 to 38% of gastric and esophagogastric adenocarcinomas have amplifications or overexpressions of HER2. If it is an G junction tumor, probably slightly more, 32% versus stomach tumors, which are 21%. Now, this overexpression actually varies according to whether histologic type and then also according to the differentiation in pathology. For example, intestinal type has more possibility of being HER2 positive than the diffuse type of gastric cancer. And with regard to the differentiation, again, well differentiated and moderately differentiated has probability to express HER2 more often. It's not uncommon. If you look at the context of what is the percentage of alterations in breast, it's about 17%, which is a significant discussion in HER2 breast. But then in gastroesophageal, it is 16.1%. So it is a significant disease. And which are the patients in which we are interested to see how we can intervene in these diseases? Unresectable, locally advanced, recurrent, or metastatic gastric or esophageal adenocarcinomas are the specific criteria for which we want to treat these patients with. And then again, there are some specific criteria as far as the pathology immunohistochemistry goes when we define the HER2 in these patients as compared to the breast cancer. You need to be specifically looking at the pathologist looking at the basolateral or the lateral membranous activity. That's the key as compared to the circumferential activity in the breast cancer, basolateral or lateral membranous activity, and then based on that you would tell whether it is strong and complete, or whether it's weak and moderate, or whether it's faint or barely perceptible. Based on that, you would give an IHC score of 3 plus, 2 plus, or 1 plus, and then go on to do fish as needed, and based on that you would select the patient. And how do we treat these patients? There are some first line data sets to look at, and then there are some second line data set to look at. We'll first look at the first line data available. How do we treat these patients? The most important first line trial which we need to know is the phase 3 study, the ToGa trial, in which trastuzumab was added to the standard chemotherapy in patients with HER2 positive advanced gastric cancers. And this is the ToGa trial design, in which the chemotherapy in the form of cisplatin 5FU was compared with cisplatin 5FU plus trastuzumab. You can replace 5FU with capecitabine, that's an option. And then these patients were stratified according to whether they were advanced disease or metastatic disease, whether there was G junction or gastric cancer, measurable or non-measurable, and so on and so forth. And capecitabine, 5-fluorouracil, cisplatin doses are given here, but the key is trastuzumab, and you continue trastuzumab until disease progression. This is the primary endpoint. The primary endpoint is significantly superior at 13.8 months as compared to 11 months with chemotherapy alone. And this is the secondary endpoint, which is again statistically significant, 6.7 months superior to 5.5 months with chemotherapy alone. The combo with trastuzumab plus chemo as compared to 34% with chemotherapy alone overall response rate. So based on this, it is secondary efficacy parameters were also met, and all of them proved to be statistically significant. And trastuzumab can reduce the risk of death by around 26% as compared to reference chemotherapy with a hazard ratio of 0.74. And you have a median survival prolongation of 3 months. So all this has become a meaningful clinical data based on which in first line trastuzumab addition to chemotherapy can be called as established standard of care in HER2 positive gastroesophageal cancer. And there are some more interesting subgroup and out of ToGa. It's very meaningful to know as far as our clinical applications goes. For example, it is rose from 0.74, which was the total population, to 0.66 in IHC3 patients. Again, something to note is that in patients who are FISH positive but who are IHC negative, it was not as effective as if it were to be IHC3 positive. The other question that was asked is whether the maintenance trastuzumab dose can be escalated in a different trial. That was a Helios trial in which 10 milligram per kilogram every 3 weeks as compared to 6 milligram per kilogram did not prove to be useful. So our standard dose is quite okay. And this is one of our own patients who presented to us in November 2019, a 62-year-old male who had advanced disease with liver secondaries and turned out to be IHC positive, and also this is IHC3 positive. And you can see that this patient had a good patient presented with both disease in the stomach and also nodes and also hepatic secondaries. And this is after 4 cycles of trastuzumab in addition to oxaliplatin based chemotherapy. You can see that the response in the primary site, and I'll also try to show you the response in the liver secondaries here. And the nodal disease were also not perceptible in the scan. So it was qualified as a very good partial response with oxaliplatin based chemotherapy with the addition of trastuzumab. So what we thought is there is such an excellent response. The family was also keen, and the patient went on to get surgery done at this point, and turned out that there was a pathological response, and went on to complete a few more cycles of chemotherapy, and then the patient is on maintenance trastuzumab. Surgery was added. It's a metastatic disease, but still it was thought that a single site in the liver. So we even though I don't say that is the standard of care, but then I'm just narrating what happened to our patient, just to illustrate at the point that we can exactly reproduce the ToGa trial response. Experience with our own set of patients. So once we see that the trastuzumab can do something more when you add with cisplatin-based chemotherapy, it's only logical for us to consider whether other HER2 blocking agents would do the same. For example, one would think whether lapatinib would do the same, whether I can switch around with chemotherapy, with oxaliplatin-based chemotherapy, which is what we did, and whether paclitaxel can be added, so on and so forth, and whether a TDM1 would do the job and pertuzumab, trastuzumab would do the job. We look at what is the experience available so far. And even though the NCCN at this point would allow you to extend your chemotherapy arm from cisplatin doublet to oxaliplatin or paclitaxel, but let's look at what is the experience with the other options. With regard to the doublet therapy, the pertuzumab, trastuzumab is the JACOB trial. The one-line answer is there was no benefit of adding trastuzumab and pertuzumab to the standard cisplatin-based chemotherapy. And that's the overall survival data from the JACOB trial. The doublet was not statistically significant to the, I would say, trastuzumab alone. The LOGIC trial is lapatinib added to, again, an oxaliplatin-based chemotherapy, and in which a robust 545 patients were treated, again, did not prove to be useful at this point in time, as compared to breast, where we have approval of various agents. The GI cancers, particularly the esophageal and the gastric cancer, has only trastuzumab as the approved agent in the first line setting. What about second line? Let's look at what is the available data in the second line. And there is no benefit in continuing trastuzumab post progression. That's our natural thought process when we look at the breast data. But here, the trastuzumab is not useful when you continue it post progression. There is no benefit with the addition of TDM1 in the second line setting, as was shown by the GATSB trial. And that's the GATSB data. The median overall survival was not statistically significant. In fact, the hazard ratio was 1.15. And lapatinib post the progression also did not improve the outcome. So it's only natural to think whether any other option will be available for us to treat in patients in second line. So one would naturally look at all the novel agents that are today available to do the HER2 blockade, that is the antibody drug conjugates like trastuzumab deruxtecan, and we have the augmented monoclonal antibody margetuximab, bispecific antibody JW25, so on and so forth. Let's look at what is available. That's the trastuzumab deruxtecan data. This is the phase 1 data of this conjugate that has shown the waterfall plot, confirmed response rate of about 43%, and the median progression-free survival of about 5 to 6 months. But then this was carried forward into the very significant trial, Destiny phase 2 trial. This is something that we need to know. That's the gastric trial. Trastuzumab deruxtecan in previously treated patients had HER2 positive advanced gastric or GE junction adenocarcinomas. That's the trial design in which trastuzumab deruxtecan 6.4 milligram per kilogram 3-weekly cycle compared to physician's choice of irinotecan and paclitaxel in patients who have already progressed with true prior regimens. And it's very important to know that the 2 prior regimens included a lot of patients, about 100 patients who were already treated with trastuzumab based therapy, but also included some other options also. We'll come to that. But the key is that the patient should have been already treated with anti-HER2 therapy. And we already know that the phase 1 showed overall response rate of 43.2%. So what did the phase 2 data show? This is the overall survival and this is the progression-free survival. The overall survival was superior at 12.5 months versus 8.4 months with hazard ratio of 0.59. Again, PFS was also statistically significant, and the overall response rate was also statistically significant at a very impressive 51.3% as compared to 14.3%. So this trastuzumab deruxtecan did show a significantly better response rate and improved survival versus standard chemotherapy, and that's the take home. And looking at this success, one would want to innovate, add immunotherapy. There are various immunotherapy trials that are being mounted in this setting, particularly in the second line setting, some of which are important to look at so that we can look at the emerging landscape. Margetuximab plus pembrolizumab, these are the waterfall curves. Response rate of about 29 to 30% in the phase 2 trial in patients who have already been treated with more than one line of HER2 blockers. And this is the bispecific antibody data set, phase 1 study with around 30% response rate. And again, some other work is going on in the rest of the GIT, like the colorectal, where trastuzumab plus lepatinib, that is the Heracles data, with a disease control rate of 59%, and my pathway study in which trastuzumab plus pertuzumab in the metastatic CRC colorectal, and then Mountaineer, where tucatinib plus trastuzumab is being studied for metastatic colorectal cancer. Whether this will be extrapolated into the gastric setting is something that we need to watch the space. So in short, one can say at this point, as compared to the luxury of having so many agents in the breast cancer space, we have the first line approval for trastuzumab with doublet chemo, and the second line approval with trastuzumab deruxtecan whenever it becomes available. Otherwise, at this point, we need to wait for all these new agents to come in. And again, you need to be very specific with your immunohistochemistry. You need to talk to the pathologist. That's another take-home point. And there are some emerging interesting data on how the resistance emerges in trastuzumab-based therapy in these patients. So with that, I thank the organizers for the opportunity. Thank you so much.
Thank you, Dr. Raja, for the excellent summary on the anti-HER2 therapy in GI cancers, especially the gastric cancers. And one question came, but I think it is a molecular-based question, and I request Dr. Anand to respond to that again. And what organizers have told me that we will take up all the questions during our panel discussion. Thank you, Dr. Raja, and all the organizers for giving me this opportunity. Thank you all.
Thank you so much, all of you.
So, Dr. Kamaluddin, can you please join?
Yeah, thank you very much. We enjoyed the talk of Dr. Ramasamy and Dr. T. Raja. Now we will move to our next speaker, Dr. Crystal Bendinger. She is the Associate Professor of Department of Hematology and Oncology of Fox Chase Cancer Center, Philadelphia. And she will be talking on current position of IO in gastroesophageal cancer. So may I request Dr. Crystal to start her presentation. Crystal.
Yeah, so thank you very much for inviting me to give this talk today. I'm very excited to be here, and I'm sorry that we can't all be in person. So I'm going to go through the current landscape of immunotherapy in gastric cancer, although we're going to talk a little bit about esophagus cancer as well, because there's been a lot of new data that has come out in the course of the last year. Here are my disclosures. So in the past 3 years, we've really seen a very active space in immunotherapy studies in gastroesophageal cancer. In 2017, we saw the first positive data, and then 2018 and 2019, we saw sort of less positive data. But in 2020, especially at this year's ESMO meeting, there were 4 studies presented that were all very exciting, and we're going to do our best to try and get through all of them. So essentially, the first studies we're going to talk about are the third-line trials of immunotherapy, and you are all aware of this data. This is ATTRACTION-2 and KEYNOTE-059. ATTRACTION-2 was the randomized phase 3 study of nivolumab versus placebo, and although this was a multinational study, it was majority Asian patients, and this demonstrated a response rate of 11.2%, as well as an overall survival benefit associated with the use of nivolumab. Pembrolizumab was studied in a single-arm phase 2 study with a similar response rate of about 15%. In this study, both PD-L1 positive and PD-L1 negative patients were enrolled, and ultimately the benefit was really seen in the PD-L1 positive population. And with the caveats of cross-trial comparisons, you can see that overall survival, 12-month survival, was similar between the 2 studies. And this resulted in FDA approval of pembrolizumab for the PD-L1 positive population in the US, and the use of nivolumab outside of the US in third-line therapy. So understanding that immunotherapy was better than placebo, the next natural question was to ask whether immunotherapy was better than chemotherapy in the third-line setting. And in 2018, the JAVELIN 300 study was published. This was a study looking at Avelumab versus chemotherapy in patients with gastric or GE junction cancers who had received 2 prior lines of therapy. And this was a disappointing phase 3 study. Most of these patients had received irinotecan in the third line as part of this trial. And unfortunately, there was really no difference in median overall survival between Avelumab versus chemotherapy. And in fact, the median progression-free survival was better with chemotherapy than with Avelumab, and the disease control rate was a little bit better. The thing that I take home from this study, however, is that chemotherapy and immunotherapy are both options in the third line setting, and data that I didn't have up here is that the immunotherapy toxicity benefit was actually better. There was less toxicities in the third line. So something to think about when you get to third line therapy, toxicity versus disease control. So moving from third line to second line, KEYNOTE-061 is a study that we are all very familiar with now. This was presented in 2018, and it was published at the end of 2018. And this was a second-line study. This looked at gastroesophageal cancer patients who had progressed on 1 prior line of therapy. It initially enrolled patients regardless of their PD-L1 status, but after enrollment of a little under 500 patients, the Data Safety Monitoring Committee recommended that the study be rewritten to enroll CPS 1 or greater patients, and that the primary endpoint of the study was overall survival and progression-free survival in the CPS 1 patient population, the curve in the middle. In the intent to treat population, there was really no difference in survival between the 2 arms, although if you look at that CPS greater than 1 population, the curves do seem to switch at about the 50% mark, suggesting that for the patients that derive benefit, that benefit can be long-lasting. In the patients who were PD-L1 negative, there was really no benefit. In fact, paclitaxel had a better overall survival. And in an exploratory post-hoc analysis of high PD-L1 expressors with a CPS of greater than 10, there was a survival benefit seen with pembrolizumab over paclitaxel, with a 2.4-month improvement in overall survival. So something to think about. What has come up from this study has actually been some additional subsequent subset analyses that have been presented at this year's meeting. The first was looking at sequencing of therapy. This was presented by Harry Yoon at World GI this year, suggesting that patients who received pembrolizumab and then went on to receive paclitaxel, ramucirumab, or really any other therapy had a better survival compared to the patients who got paclitaxel and then went on to receive any therapy. And while this is exploratory and certainly shouldn't drive decision-making, it is something to think about when you're considering second-line therapeutic options in your patients, especially in patients where you know they have a high CPS score. The other study that was presented at this year's ASCO meeting looked at tumor mutational burden. We already heard about this in the first talk of the day. And in, again, another exploratory subset analysis in patients who had a high tumor mutational burden, pembrolizumab seemed to have a better survival compared to paclitaxel. And if a patient had a low TMB, there was really no difference between pembrolizumab and paclitaxel. In fact, the paclitaxel arm had a better survival of almost 3 months. The other thing that came out of this study in the second line was actually the emergence of MSI high tumors in this disease being exquisitely responsive to immunotherapy. Approximately 5% of this study's patient population was MSI high. Again, these are 15 and 12 patients, so small patient population. But overall survival with pembrolizumab was not reached, and the response rate was significantly better with pembrolizumab compared to paclitaxel, suggesting that for MSI high tumors, pembrolizumab should be the default treatment of choice over paclitaxel after progression on platinum fluoropyrimidine frontline therapy. And in fact, both pembrolizumab and nivolumab are FDA approved for second-line therapy in MSI high tumors. So I would be remiss if I didn't at least mention some second-line esophagus studies where immunotherapy has been active. Again, these are studies that were recently published in the last year. The Attraction 3 study was a Asian study, essentially evaluating nivolumab versus chemotherapy, and that was physician choice of chemotherapy. And although response rates were similar, overall survival was actually improved with nivolumab. And then in the KEYNOTE 181 study, which was also a international study, but was almost 2/3 non-Asian, this enrolled patients with esophagus cancer and basically demonstrated that there was a survival benefit. And in subgroup analyses of this particular study, looking at squamous cell carcinoma patients and those with a CPS of 10 or greater, there was even stronger benefit. In fact, pembrolizumab was FDA approved for squamous cell cancer patients with a CPS greater than 10 based on KEYNOTE 181. So knowing that second-line therapy for gastric cancer, there may be some benefit in subpopulations with pembrolizumab and that there's a benefit in third-line therapy, it's only reasonable to bring this drug to the first-line setting, especially because we know that this has potentially a better side effect profile than traditional chemotherapy. And so the first study that really looked at first-line therapy, or the most recent study, one of the most recent studies that looked at first-line therapy as maintenance strategy was the JAVELIN 100 trial. This was presented at ASCO GI this year. And this was, again, a large phase 3 study, basically taken patients who had received 12 weeks of platinum 5-FU in the frontline setting. And if they had not had disease progression, randomizing them to continuation of their chemotherapy or a switch to Avelumab given every 2 weeks. The PD-L1 expression in this patient population was done using the 7310 PharmDx assay, which is not the standard assay that we use to look at PD-L1 expression for pembrolizumab therapy. And as you can see, the side effect profile really favored Avelumab compared to chemotherapy. However, there was no benefit in overall survival in the PD-L1 positive population or in the overall intent to treat population. So this was a really disappointing study because even though we expected, at least for the PD-L1 positive population, to really see a benefit, there really wasn't any improvement. So at this point, there is no role for a switch to immunotherapy and maintenance therapy in frontline treatment. In frontline therapy. So the first of the the first of the frontline studies that we'll think about today is the KEYNOTE 062 study. And this was the first study that was presented for frontline therapy with gastric and gastroesophageal cancer. This was a study looking at adenocarcinoma patients with gastric or GE junction, primary tumors who were HER2 negative, and PD-L1 positive with a CPS of greater than 1. This was a study of about 763 patients and randomized patients to either pembrolizumab alone, pembrolizumab plus cisplatin 5-FU chemotherapy, or cisplatin 5-FU chemotherapy with a placebo. And patients for the 5-FU could have received either infusional 5-FU or capecitabine. This was a complicated study. There were actually 4 different primary endpoints. And if any of the 4 primary endpoints were positive, then there was a second analysis for a secondary endpoint. And so it was a really complicated study, and we think that that may have actually impacted some of the results. So these are the results, the most recent updated results presented at ESMO Asia in the fall of this past year, and then published in JAMA very recently. And this is looking at pembrolizumab monotherapy versus chemotherapy. And in the primary population with a CPS of greater than 1, there was really no overall survival benefit to pembrolizumab compared to chemotherapy, which actually meant the study met its primary endpoint, because the first primary endpoint of the study was whether pembrolizumab was non-inferior to chemotherapy. And in fact, that's the case for this population. They then did another analysis looking at patients with a CPS of greater than 10, and in fact, there was a survival benefit with pembrolizumab, but I want you to look at the beginning of the curves in both of those overall survival curves, and you can see that initially pembrolizumab actually does worse than chemotherapy, and that the curves cross anywhere between 12 months or about 9 months with the CPS greater than 10, and so that the patients who do derive benefit derive a greater benefit, but the patients who are not deriving benefit may actually do worse upfront. This study also looked at the MSI high population, which was about 6%, if I recall correctly, for this patient population. And the MSI high group actually really did better with pembrolizumab upfront compared to chemotherapy, suggesting that for an MSI high patient, using pembrolizumab first as opposed to chemotherapy should be the standard of care. Again, small numbers, but very similar data to what we saw in the second line. With respect to the other analysis looking at pembrolizumab plus chemotherapy versus chemotherapy alone, you can see that those curves overlap in both the CPS greater than 1 and CPS greater than 10 population. In fact, there was no difference in survival between the 2 arms of the trial, demonstrating that the addition of pembrolizumab to chemotherapy actually was not associated with any survival benefit. And if you look at the MSI high group, in fact, the pembrolizumab group, again, did better, although there was actually a detriment in the initial few months when chemotherapy was added. But again, in the MSI high population, a terrific benefit that seems very durable with the use of immunotherapy. The overall response rate was actually higher when you added pembrolizumab to chemotherapy, but chemotherapy had a greater response rate when compared to pembrolizumab alone. So when we think about patients for whom we're thinking about frontline therapy, for somebody who has a big disease burden, chemotherapy probably provides greater disease control than pembrolizumab, with the exception of in the MSI high population. Interestingly, when you add pembrolizumab to chemotherapy, there's about a 10% higher rate of toxicity-related issues related to treatment, higher rates of immune-mediated toxicities, and about a 10% higher rate of treatment discontinuation when you add immunotherapy to chemotherapy. So adding immunotherapy is not a free ride. In fact, it actually is associated with higher rates of toxicity and treatment discontinuation. So at this year's ESMO meeting, we now have a couple more studies, and these were data that was presented in September, and so I'm excited about these studies, and we'll talk a little bit about how all these studies kind of came, how we should be thinking about them. So Attraction 4 was a frontline study out of Asia. It basically looked at unresectable HER2-negative gastric and GE junction cancer patients who are treatment naive and randomized them to oxaliplatin-based chemotherapy as opposed to KEYNOTE-062, which was cisplatin-based, and used nivolumab versus placebo. You can see that the response rates with the addition of nivolumab were actually higher, and the disease control rate was actually a little bit higher with the addition of nivolumab, and the duration of response was higher when you added nivolumab to chemotherapy. However, when we look at the primary endpoints, they had co-primary endpoints of progression-free survival and overall survival. There was a benefit to progression-free survival of about 2 months, and this was statistically significant. And there was about a 15% improvement in the 1-year progression-free survival rate. So technically, this was a positive study. However, there was no benefit in overall survival. So the median overall survival was 17 months in both arms, which was not statistically significant. Immediately after this presentation was immediately before that presentation was the Checkmate 649 study. And this was a global study looking at oxaliplatin-based chemotherapy with nivolumab. And in this trial, there were actually 3 arms to the study. The one arm of nivolumab and ipilimumab was actually closed early due to toxicity. And so the analysis presented at ESMO this year was the nivolumab plus Zelox or Folfox versus Zelox or Folfox alone. This was a very large study, almost 1,400 patients. So this is actually double the size of the other 2 studies that we just talked about. Again, we saw an improvement in response rate from 45% with chemo alone to 60% with nivolumab plus chemotherapy. And again, a better duration of response when we added nivolumab to chemotherapy. When we look at the survival curves, the primary endpoint of this patient of this study was PFS and OS, and the primary endpoint was actually measured in the CPS greater than 5 population. So PD-L1 positive patients with a CPS greater than 5. This is in contradistinction to the Attraction 4 study and the KEYNOTE-062, and we'll get into that in a couple more slides. So overall survival here was actually statistically significantly improved by approximately 3 months with the addition of nivolumab to chemotherapy. The 12-month survival rate was also improved by about 10%. When they looked at the CPS greater than 1 population, so anyone who is PD-L1 positive, there was a survival benefit as well. It was slightly less. And then they looked at all randomized patients, including patients who may not have been CPS positive. And there still was a survival benefit, although that survival benefit was lower in that combination, in the all-comers population. They also looked at progression-free survival, and progression-free survival in the CPS 5 population or greater did actually improve with nivolumab, but you could also see that it was improved with in the other populations, CPS greater than 1 and all randomized, although the survival benefit was, the progression-free survival benefit was not as good. But with that benefit in terms of survival and progression-free survival, we get higher rates of toxicity. There was about a 15% increase in treatment-related events, and there were more treatment-related events that led to discontinuation of therapy in the nivolumab arm compared to the chemotherapy alone arm, and a numerically higher rate of treatment-related deaths with the addition of nivolumab. So something to think about for our patient population. Again, immunotherapy does hold some promise, especially with the Checkmate 649 study, but the trade-off is additional toxicity. And the speakers for both the Attraction 4 study and the Checkmate 649 study suggested that these regimens with nivolumab plus oxaliplatin-based chemotherapy should be considered a new standard of care, but this is in contradistinction to the KEYNOTE-062 study. So why is there such a difference between these 3 trials? I think one is that the sample sizes were different. KEYNOTE-062 was 700 some odd patients. Attraction 4 was also a 700 patient study, whereas Checkmate 649 was over 1,500 patients. The geographic locations were a little bit different in the makeup of this, as were the breakdown of the tumor locations. Checkmate 649 included esophagus cancer patients. The other 2 studies were mostly gastric cancer patients. The chemotherapy backbones were different between 062 and Attraction 4 and 649. Oxaliplatin is thought maybe to be a little bit more immunogenic. and there is some data to suggest that maybe oxaliplatin has a numeric benefit compared to cisplatin based on the real 2 data. The populations that were enrolled were actually different in the different studies. So 062 in PD-L1 positive patients only, whereas the other 2 studies enrolled all comers, and the primary study population was also different between each of these studies. But what's interesting is the number of patients who were PD-L1 positive. So in 062, only about 36.8% of patients had a CPS of greater than 10, whereas in 649, 60% of patients had a CPS greater than 5. So this was really a study that was stacked to have an improvement in benefit because the majority of the patients in the study were PD-L1 positive, and in fact, 82% of patients had a CPS of greater than 1. The other thing that's important to note in this study is that there were differences in subsequent therapies. In KEYNOTE 062, approximately 50% of patients received subsequent therapy, with 13% of patients receiving chemo and about 4% going on to receive additional immunotherapy. Whereas in ATTRACTION 4, 66% of patients went on to receive a subsequent line of therapy, with 12% receiving subsequent nivolumab. And in CheckMate 649, only 39% of patients went on to receive a subsequent line of therapy. 8% went on to get chemo and 2% went on to get nivolumab. And as we all know, subsequent therapies, second-line therapy, third-line therapy, actually have survival benefits. So in CheckMate 649, 60% of patients did not receive any additional line of therapy, and that may actually result in a bigger overall survival benefit from that frontline treatment compared to the other 2 studies where the survival benefit was not as great, because we could maybe make up some of that survival loss with subsequent therapy. I would also be remiss if we didn't talk about the KEYNOTE 590 study, which was also presented at this year's presidential session at ESMO. This was a study looking at pembrolizumab plus chemotherapy with cisplatin 5-FU versus the same chemotherapy background with placebo. Again, this enrolled patients with esophageal adenocarcinoma or squamous cell carcinoma. They looked at squamous cell patient populations, those with a CPS greater than 10, and the overall population, as well as patients who just had a CPS greater than 10 regardless of histology, as well as the entire study population. And there were survival benefits and progression-free survival benefits associated with immunotherapy. And I think the new standard of care in frontline esophagus cancer, at least in squamous cell cancers, is going to be pembrolizumab plus chemotherapy with a platinum fluoropyrimidine combination. And I think in gastric cancer and GE junction cancers, that standard is also probably changing. So the final study that I want to mention is the CheckMate 577 study. This is a study with very early follow-up, so I don't think this is enough to change our standard practice, but I think it's going to evolve. This was a study of adjuvant therapy for immunotherapy. These were all patients with stage 2 or stage 3 esophagus and GE junction cancers. They could have been adenocarcinoma or squamous cell carcinomas, and they could have received any neoadjuvant chemoradiotherapy regimen followed by surgical resection. And about 3/4 of patients had the cross regimen, but approximately 1/4 of patients had some other platinum-based chemoradiotherapy regimen. The patients had to have an R0 resection, but would have had to have residual pathologic disease, aka they couldn't have had a complete pathologic response, and they were randomized to nivolumab for a year or placebo. And with 12 months of follow-up, there was a statistically significant improvement in median disease-free survival from 11 months with placebo to 22 months with nivolumab. And in patients with esophagus cancer, those with squamous cell carcinomas, and those with pathologically node-positive disease, there was a statistically significant benefit with nivolumab. We don't have the overall survival data for this study yet, and I think we're all eagerly awaiting that before we can put this into play as standard of care. But I think that this is also an evolving area, and I would anticipate that down the line we may be thinking about nivolumab in the adjuvant setting. And of note for this study, patients could be randomized up to 16 weeks after surgical resection, which gives people time to recover from their esophagectomy and then go on to this treatment. So there are some things that I think are coming down the pike that I think we should be paying attention to. There are some early studies, phase 1 and phase 2 studies, that are looking at combining immunotherapy with VEGF-targeted therapy, specifically TKIs. There is a study looking at lenvatinib plus pembrolizumab in gastric cancer that looks very promising, the LEAP study, and then the REGO-NIVO study, which has been presented looking at regorafenib and nivolumab, also demonstrating promising response rates and disease control rates. We are seeing frontline therapy, the KEYNOTE 811 study, looking at trastuzumab plus pembrolizumab and chemotherapy in the frontline. And Yelena Janjigian's early data suggests a 100% disease control rate, which is super exciting. And we await those data. And then we've heard about margetuximab in the HER2 positive space at the previous talk, but there is data. There is a study going on right now looking at margetuximab with immunotherapy and a non-chemotherapy frontline regimen for the HER2 positive patients. There are a number of early phase studies looking at combining checkpoint inhibitors with other co-stimulatory or co-inhibitory molecules. And then we're starting to see immunotherapy move into the adjuvant setting and perioperative setting in gastric cancer with ongoing studies looking at FLOT and FOLFOX plus or minus immunotherapy. And there are other studies looking at immunotherapy in combination with chemoradiotherapy in esophagus cancer. So where do I think we stand right now with immunotherapy in gastroesophageal cancer? I think there's an absolute role in third line for esophagus and gastric cancer. In fact, I think in the third line therapy, based on JAVELIN 300, you can decide based on toxicity, do you want to put your patient on immunotherapy versus chemotherapy? I think PD-L1 status could help drive some of that decision, as could tumor mutational burden. I do think there is a definite role for both nivolumab and pembrolizumab in the second line of esophagus cancer with squamous cell histology. And in fact, these both drugs are FDA approved in this setting. I do think that there is a very strong role for MSI high tumors in the frontline setting. And in fact, getting MMR or MSI status at the initial diagnosis of metastatic disease is important, because I do think these patients probably should receive a checkpoint inhibitor over chemotherapy. And you may also consider immunotherapy with pembrolizumab in patients who have a CPS of greater than 10 and low disease burden, where response to therapy is not really necessary and someone wants to avoid the toxicities of chemo. I think based on the Checkmate 649 study, we're going to see nivolumab move into the front line in combination with oxaliplatin fluoropyrimidine therapy. I don't think it's enough that everyone needs to get it. There's certainly some increased toxicity associated with this. But I think that for patients who have a high CPS, at least a CPS of greater than 5, that this should be a consideration. And then I do think that we are going to see, based on the Checkmate 577 data, an evolution of this of nivolumab in the adjuvant setting after trimodality therapy for esophagus cancer. I do think that the role of pembrolizumab in the second line or immunotherapy in the second line still needs to be determined. There may be subpopulations where giving immunotherapy over paclitaxel would be a good idea, potentially in those with a high TMB. We're still waiting to see whether immunotherapy combined with perioperative chemotherapy and gastric cancer changes outcomes. And we're waiting to see how other targeted combinations shake out. So I think this is a very active space. It's very exciting right now to be a gastroesophageal cancer doctor, because I think we're going to see immunotherapy moving into earlier lines, but I also think we're going to end up needing to subdivide our patient population even further, and it's going to be subpopulations, not an all-comers treatment. And again, I'd like to thank the organizers for inviting me today for this great session.
Thank you, Dr. Crystal. It was an elaborate discussion. I think you have tried to cover all the updated data, and I'm sure we all were benefited from the discussion. And as we are not on time, a bit behind the time, there is one question I will appreciate if you can just answer the chat box. So now it's a pleasure to invite a good friend of mine, Dr. Vineet Talwar, who is the Director of Medical Oncology at Rajiv Gandhi Cancer Institute. And it's also interesting to invite the organizer, because he's the host. But now I have the privilege to invite the host to be the speaker, Dr. Vineet Talwar, who will be talking on the real-world evidence and pan-Asian adapted ESMO guidelines on gastric cancer. This is the crystal ball of gastric cancer session, and he will be the first speaker of the session. Dr. Vineet Talwar, over to you.
patient's burden of disease and validation of safety and tolerability and efficacy of the regimens in clinical practice is sometimes not seen. And so would be the ethnic variation on a country-wise data. And limitations, the power of the study, because the fact that it is retrospective, and of course rare drug-related toxicities may not be captured. This can happen in a real-world evidence data, but of course this can be corroborated with the standard clinical trials which have taken place. So I have two data sets. One is from the Asian data set, another is from the European data set. So this was to see the efficacy of ramucirumab, whether it was in combination or it was in monotherapy. Most of these patients were in combination therapy, about 85%, and 15% were as monotherapy. And this study was from June to December 2015, and about 250 patients were enrolled according to the extended access program. And the decision was to provide combination therapy or monotherapy based on the discretion of the physicians. And this was the progression-free survival and the overall survival. When you can see the PFS was about 1.8 months, and the median overall survival was about 6.5 months when you used a single agent, that is ramucirumab alone. And when it was used in combination, it was 3.8 months versus 8.6 months, which was the median overall survival. And when you use the combination of ramucirumab plus paclitaxel, you found that at 6 months, the progression-free survival was about 67%. And if it was alone as ramucirumab, then it was 28.5%. The adverse event profile, when you use a singlet with a doublet, you find that the neutropenia and febrile neutropenia, they're about 20 to 25% grade 3 to grade 4 events, probably because of the addition of paclitaxel. One patient had grade 4 febrile neutropenia. Otherwise, this combination was very well tolerated. GI perforation was seen in about 1.7% of patients where there was a combination of ramucirumab and paclitaxel. The other data is from Europe. This was ramucirumab as second-line therapy again in metastatic gastric cancer. This was a multi-institutional observational retrospective study in patients who received ramucirumab during the compassionate use program, something like the EAP, which was in the Korean study. Median follow-up in this was higher, that was about 11 months as compared to 9 months, which was earlier. And in this, again, a majority of patients received a combination, that is about 90 patients received ramucirumab plus paclitaxel, and about 10% patients had ramucirumab alone. And again, you can see here, when you see the median progression-free survival as compared to monotherapy, it was 4.5 months versus 2.7 months. And so was the OS. This was 8.3 months versus 4.8 months, which was comparing to the clinical trial, that is the Rainbow trial, which was done. Safety analysis also mirrored the Asian data, in which neutropenia was there in most of the patients, and also 6 patients had hypertension. And no grade 3 adverse events were documented in patients who were treated with ramucirumab alone. And fortunately, there were no treatment-related deaths in this patient. So if you collate the data, that is East and West, when you compare it with the standard, that was the Rainbow standard, the Rainbow trial, you find that the median progression-free survival is hovering between 3.5 to 4.5 months, which is almost the same across the ethnicities, across the boundaries. And so is the median overall survival. This is about 8.5 to 9.5 months as compared to the current standard, which was the Rainbow standard. And based on these patterns, the real-life practice, the data allows us to consider ramucirumab and paclitaxel as the new standard care in the second-line treatment of metastatic gastric cancer. And it has a good safety profile and tolerability, which makes it possible to treat cancer while maintaining, of course, the quality of life in these patients, which is paramount whenever you treat metastatic gastric cancer patients. So these were the real world data key takeaways, which were compared with the Rainbow trial, and they found that there was a stark similarity between both the two groups. So coming to the Pan-Asian Adapted ESMO guidelines, which were presented in the Annals of Oncology, and also the ESMO guidelines, now they are being again regrouped after the ESMO symposium, which Dr. Crystal has very nicely alluded. So prior to that, you have an inoperable metastatic gastric cancer patient, palliative chemotherapy. If the general condition, performance status, and the ECOG PS is good, if it is not good, then the patient is subjected to best supportive care only. Then after that, the substratification is HER negative or HER positive, as Dr. Raja had nicely alluded about HER positive patients. And of course, consider clinical trials of novel agents. That is always there in the treatment paradigm. So now if the patient is HER negative, the first line would be a combination of fluoropyrimidine and platinum, or sometimes a triplet combination if the patient's GC is very, very good, or it's a very fit patient. And that could be a modified DCF or a DOX. These patients, they benefit from that. Anthracyclines are known to have more side effects, so now they are fading into the background. So possibly in most of the patients, it is a doublet of fluoropyrimidine and platinum. Then if the patient is HER positive, then it is trastuzumab plus fluoropyrimidine and platinums according to the ToGa trial. And subsequently, second line chemotherapy at progression, or now is the time when you think of the tumor mutational burden, the PDL1 assay, and also the MSI status. So as Dr. Crystal has rightly pointed out, now at the inception, it is always better to do a MSI status and a PDL1 assay so that the regrouping of these patients can be done. And of course, I'm sure in the times to come, in the near future, those would be put into the guidelines as these immunotherapy drugs are migrating up and up in the treatment lines. So if you have a good ECOG performance status after the second line, then of course you can give paclitaxel and ramucirumab, which has the level 1 evidence at present. And along with that, if you have MSI, MSI high, which I told that it should be done, then these can be subjected to pembrolizumab or nivolumab. Now, if the ECOG is PS2, then of course you can think of a singlet. That is, it can be a monotherapy with chemotherapy drugs, or it can be ramucirumab alone, which was alluded to you. And if it is MSI again here, pembrolizumab and nivolumab can be given in these patients. If the PS is poor, then of course the patient should be subjected to only best supportive care. So now you see here in this whole situation, the first line treatment earlier was only chemotherapy. Now the immuno-oncology drugs are gradually moving up the ladder, and in due course of time, it will be found that they will be in first line, as Dr. Crystal has rightly told. And based on the MSI high and the TMB, that is a tumor mutational burden, the PDL1 status, these can be regrouped again in the second line. And if the patient has to be given chemotherapy and VEGF combination, level 1 evidence still is for paclitaxel and ramucirumab. So the general condition, the performance status of the patient, the HER status, the PDL1 status, the MSI status, all these are going to decide the subsequent treatment therapies which the patient can be offered. Of course, the financial overtones are there. If they are there, then of course, patient can be subjected to a doublet chemotherapy in first line, and in second line, it can be a single agent chemotherapy or a combination with the ramucirumab, wherever the patient resistance plans are there. So these are the latest NCCN guidelines. Again, to reiterate, first line, you can have 2 or 3 drug combination. And in this, oxaliplatin is generally preferred over cisplatin due to toxicities. And again, here here the epirubicin, that is the anthracyclines, they are fading out now because of the fact that of the trial in which it was shown that addition of anthracyclines only increase the toxicity but does not help in the survival. Now, when you come to the second line, and dependent on the prior therapy or the performance status, the preferred regimens in the chemotherapy status is paclitaxel and ramucirumab. And for second line and subsequent therapy, if MSI is high or if you have a deficient mismatch repair, these patients are the ones who can be subjected to the immuno-oncology drugs, that is pembrolizumab and nivolumab. And third line and subsequent therapy, if the PD-L1 expression is high, the higher the expression, better the response. And in third line, the drugs which have not been used, if the general condition is very good, you can subject these patients to singlet chemotherapy protocols. So I think I will stop here. I thank you for your patient hearing.
So thank you, Dr. Vineet. I think we heard from Dr. Crystal and Dr. Vineet. Crystal has covered the portion of the immunotherapy portion, and our good friend Dr. Vineet Talwar has shown us the real world evidence, and also he has touched upon the adopted guidelines and the NCCN guidelines. I want to thank the organizer for inviting me, and it was a great pleasure to be a part of this great program from Bangladesh, and I wish all the success, and I hope the remaining part will be enjoyable and will be enjoyable. Thank you very much.
Thank you, respected faculty members, for such an informative session. Next on, we have a panel discussion in our time. For this session, I would like to invite Dr. Ankur Bahal, sir, who is the senior consultant in medical meta-oncology at Max Specialty Hospital. Please brief this session as a moderator for this panel discussion. Also, I would like to invite the panelists for this session, Dr. Arun R. Warrier, Chief Consultant Medical Oncologist at Esther Medicity Hospital, Kochi, and Dr. Anjana Jain, Assistant Professor, CMC Medicine. Thank you.
Yeah, thank you, Dr. Pallavi, and congratulations to the organizers for this great evening. With mushrooms of webinars happening, it's still keeping its charm. So I think my slides are visible and I'm audible to you. And I welcome Dr. Arun Warrier from Kochi and Dr. Anjana Joel from Vellore. Both of you here, Dr. Warrior and Dr. Joel.
Yep.
Yeah.
Dr. Arun here. I think I'm audible.
Yeah, you are audible. So we start this case, which is a metastatic gastric cancer, and it's a case